Okay. All right. Um, okay. Good afternoon, everybody, and then good morning to Ali. And we had last week a little hiatus in our regular series because of what was going on. Although by then it had sort of settled down. But it's great to get back into the swing of things and to present another one of our surgical grand rounds. And it is with great pleasure that I'd like to introduce Dr. Ali. Is it Cadili or Sadili, Ali?
Cadili. Cadili.
Cadili, from the West Virginia University School of Medicine. And a little bit about Ali. We were just chatting. He went to medical school in Canada at the University of Saskatchewan, and then did his postgraduate surgical training at the University of Alberta in Edmonton. And he's got a couple of masters. He's got a master's of science in experimental surgery. He also has a master's in business administration from McGill. He did a post residency fellowship in surgical critical care at the University of Connecticut. Then, after spending several years on faculty in Canada, he 2 years ago came down to the States and, as I said, is now on faculty at the West Virginia University Medical School. He's got a particular interest in pancreatic disease, both benign and malignant. And today he's going to talk to us about um, the management of acute pancreatitis. So, without more of ado, hand the microphone over to Ali. Thank you very much.
Great. Thank you very much. And it's a pleasure to be here. I'm just trying to share my presentation here. Um,
You should be able to.
yeah. Just one second.
I'll just make sure that you can. I think you can.
Okay. Um, Sorry, it's a new computer and I don't know why it's not. Um, Let me see here.
If it's giving you problems, you can email it to me.
Yeah.
Let just take a minute. Oh, here
Okay.
we go. Beautiful.
Perfect. Okay. So, yeah, so we're going to talk about severe acute pancreatitis. Um, so we'll talk about the diagnosis and etiology of severe acute pancreatitis. Specifically, we're going to hone in a little bit on biliary pancreatitis because it's a bit of a special situation. We're going to talk about the fluid management, the nutrition, which becomes an issue early on. Some of these people stay in the hospital for weeks, sometimes months, antimicrobial therapy, and surgical management. So the diagnosis, and these are the revised Atlanta criteria, which is either abdominal pain consistent with pancreatitis. It's usually central abdominal pain radiating to the back, an amylase or lipase 3 or more times the upper limit of normal, or number 3 is cross-sectional abdominal imaging consistent with pancreatitis. And if you'd notice, you can diagnose this with 2 out of the 3 criteria, meaning you don't strictly need imaging, and that's how some of these were diagnosed in the past.
We're still on your title slide, incidentally.
Oh,
Yeah, there you
okay.
go. Perfect.
Yeah. So the These days, most people coming to the emergency rooms in North America will get a CT scan right away. It should be noted that you can diagnose this without imaging if you meet the first two criteria, if they have classical abdominal pain and the right lab work. But if you're using these alone without imaging, you'll fail to detect acute pancreatitis in 25% of patients, and there'll be a false positive of 10% where it will diagnose it with pancreatitis, but it was actually something else. Do you see the next slide? Yeah.
Yep.
So for the CT abdomen and pelvis with IV contrast, which is really now the standard method by which it is diagnosed in most patients in the modern era, it's critical to note that the patient must be hemodynamically stable before you send them over to the CT scanner. Because sending them over to radiology and transporting them is not the best when you have an unstable patient. It's probably one of the worst places to resuscitate a patient. If they have impaired renal function on presentation, which is common, then the practice is to hydrate them first, then reevaluate the renal function, then repeat before CT. Because IV contrast is important to look at pancreatic necrosis versus non-necrosis. So it is useful in the CT abdomen pelvis is useful with the diagnosis, in grading the severity, and detecting necrosis, as we mentioned, which is really you're trying to assess gland perfusion of the pancreas, to detect infection, fluid collections, biliary dilation, which might give you a clue as to the etiology and the immediate treatment and management of it, as well as overall complications, in addition to other pathology that may be there. So the definitions have been revised over the decades. Currently, acute pancreatitis is divided into three categories. Mild acute pancreatitis, which is the vast majority, it's about 70% of cases. And for something to be labeled as mild pancreatitis, you'll see, they'll have the classic symptoms. They'll have elevation of lipase, amylase, and then you'll see inflammation stranding around the gland, but there's no local complications such as fluid collections, and there's no systemic organ failure of the patient. And before it used to be mild and severe. Now there's a third criterion, which is moderate severe acute pancreatitis, which is they have transient organ failure that improves after 48 hours, or they have exacerbation of their underlying comorbidities, such as heart disease, lung disease, or they have local complications. So any combination of these makes it moderately severe acute pancreatitis. For severe acute pancreatitis, really the only criteria, regardless of how bad it looks on imaging or the patient's pain or what the blood work is doing, is persistent systemic organ failure that lasts more than 48 hours, usually despite resuscitation. So the mortality is higher in severe acute pancreatitis. This is why it's important to detect this right off the bat when the patient comes in, and we'll go into that a little bit later. But half of the deaths will occur in the first week, and those are going to be due to the progression of the multi-organ system failure that just does not respond as ideally as you'd want to resuscitation. The deaths that occur after the first week are due to infected pancreatic necrosis. And that has important implications in terms of following the patient. And sometimes they get better, then they get worse. So when that happens, you have to think about infection. Interestingly, the outcome is not related to the degree of enzyme elevation. Enzyme elevations do not really correlate with disease severity, progression, or clinical impairment. They don't really guide treatment decisions. And levels can actually remain elevated days to weeks after the patient has already recovered. So it's not a very useful thing to just get daily amylase. We just use it for the diagnosis, as we mentioned earlier. The presence of pancreatic necrosis does predict deaths, major complications, hospital stay, with an 83% sensitivity and 65% specificity. And the relationship, however, between the extent of necrosis and the actual outcome is controversial with mixed results. So the important things to note is there necrosis or not? And then usually with those with necrosis get followed later with serial imaging. So there's been a plethora of scoring systems that you can apply to patients who present with pancreatitis to try to predict if they're going to develop severe pancreatitis. So, and traditionally, historically, we use the Ranson's criteria, but those are really gone by the wayside of just historical interest because they're pretty cumbersome, and then they require ongoing evaluation on presentation and at 48 hours after presentation. So there's the CT severity index, which is really looking at imaging criteria. There's the Apache 2. Which is really a measure of physiological reserve, and then Apache O, which is modified, which is obesity to account for obesity, which is now recognized as a major risk factor for progression to severe pancreatitis. There's a whole bunch of others. Um, these have a high false positive rate. They're cumbersome and complex. They're very useful for research and communication purposes, but really, practically, most of the time, you're going on an individualized case by case basis, just assessing how sick the patient is, essentially, without having to strictly calculate these in terms of management guidance. So, the factors that have been found, however, to be associated or predictive of severe pancreatitis in someone presenting with pancreatitis on your initial assessment is age above 55, BMI over 30, the level of their comorbidities, altered mental status. These are the patient factors. And then you look at the systemic inflammatory response criteria. When you have three or more criteria, that's predictive of progression to severe pancreatitis. And then lab levels that have specifically been related to severe pancreatitis are a BUN above 20, hematocrit above 44, and those are just looking at the degree of dehydration in addition to the creatinine of more than 1.3. On imaging, if you see complications like pleural effusions, multiple or extensive pancreatic criteria, pulmonary infiltrates, that's also predictive. So the scoring systems and or CT imaging, as we said, just on their own, do not really predict the risk of developing severe disease and acute pancreatitis, strictly speaking. So you have to take the whole picture into account, including the factors that we just said that were correlated. Each of the scoring systems has its own strengths and weaknesses, but overall, it's like, how does the patient look? The demographic factors, the SIRS factors, imaging, how it looks on imaging, what do the labs look like? So it's an overall clinical impression rather than just a score, which I'm sure in the near future, AI will be able to just give a score of these various things when the patient first comes in, although some of them do require for the patient to be assessed at 48 hours. So the management priorities are to first assess the severity to know what you're dealing with, then fluid resuscitation, analgesia, nutrition, which we'll go over these, and then try to get a sense of the etiology either from the history, whether there's alcohol abuse, a history of biliary disease. Abdominal ultrasound is helpful to rule out basically biliary pancreatitis with ongoing obstruction that might need treatment, serum calcium, triglyceride levels, and then if there's a mass on cross-sectional imaging or some other factor that could be the underlying etiology. So fluids, there's been a shift away from, we used to give a lot of fluids right at the get-go. They used to get almost 1 to 2 liters immediately. And then over the course of like 5 days, 7 days, they might be positive 10 liters, 13 liters sometimes. That used to be the dogma just 10, 15 years ago. Now it's early goal-directed therapy. So we're much more conservative with fluids, and it's really guided by trying to achieve a heart rate of less than 120, urine output of more than 0.5 mils per kilogram per hour, maintaining a MAP above 65, and a hematocrit level. Interestingly, in research has been really shown to be predictive of severe pancreatitis and how well the patient does. Resuscitation with Bringer's lactate is superior to normal saline in randomized control trials in acute pancreatitis. Normal saline has been found to increase the inflammatory response, increase CRP levels, which is a marker for inflammation, and increase the chance of kidney injury. And that's probably related to the hyperchloremic metabolic acidosis that you get with normal saline, which basically that hyperchloremic metabolic alkalosis will activate the pancreatic enzymes prematurely. It will help with that, which you don't want. plus Ringer's lactate has a more physiological pH of around 6 to 7.5, and it contains lactate, which is metabolized to bicarbonate, which helps actually buffer the acidosis that's developing. So this is the landmark waterfall trial published in 2022. And essentially what this showed is that they compared early aggressive fluid resuscitation, which is more kind of mirrors the old way of how it was traditionally done at the time, versus a more conservative goal-directed approach. And they found essentially that the mortality was not significantly different, but the hospital stay and rate of complications were much lower with the conservative fluid assessment. So nutritional support, it didn't before. It wasn't really that important, meaning that the patient can stay there, and after a week maybe we'd think about TPN. But it's been thought to be very important. The goal now is enteral nutrition whenever possible, rather than going straight to TPN if they can tolerate enteral nutrition. So it improves the gut mucosal integrity, reduces bacterial overgrowth, likely increases in splanchnic blood flow, and interestingly, you get less infected pancreatic necrosis, and that's probably due to less bacterial translocation across the gut, and less, basically a more physiological feeding. And it's actually been shown to decrease organic failure and mortality compared to parenteral nutrition. So now the goal is early enteral feeding, if possible, within 24 hours of presentation. Patients in whom you delay enteral nutrition would be those who are hemodynamically unstable, they have GI intolerance to feeding, or a bowel obstruction, or they just will vomit it up and they cannot tolerate it. Or situations in where, and this is a more subtle thing, where they're getting frequent necessary interruptions for investigations or interventions, and it's going to be stopped for hours before and a few hours after, where it's going to be deemed that they're not getting enough calories by the enteral route. So then you might as well just give them nutrition better than no nutrition by TPN. What we want to do is avoid maximizing the enteral nutrition in patients who are not yet resuscitated, which goes back to the hemodynamic instability, especially if they're on pressors, which diverts the blood flow away from the splanchnic circulation, because then you can actually do the opposite and risk inducing gut injury through non-occlusive mesenteric ischemia. There was a debate on maybe when you are giving enteral nutrition, is it best through just a nasogastric tube through the stomach, or do you want to put it beyond the pylorus? And theoretically, the idea was to minimize the load that you're delivering to the duodenum that's going to stimulate pancreatic enzyme release. But there's been multiple studies that have suggested that enteral tube feeds do not reduce the risks. The guidelines now recommend either as tolerated. Part of the reason for this is it's more technically difficult. It's not available in all centers. It's a bit more time consuming rather than just placing an NG tube at the bedside, nasogastric tube at the bedside. And part of the reason also is they found that when you feed through the jejunum and you bypass the duodenum completely, you're still getting activation of the hormonal pathways and the cholinergic enteropancreatic reflexes. And so you're still getting pancreatic stimulation. And that reduction in stimulation was only detected when the enteral nutrition is given way distally into the mid to distal jejunum. So either is acceptable. There's been no difference. The other thing, which is just a little bit of a practical point, is you cannot use nasogastric aspirates as a surrogate for feeding intolerance, unless they're putting out more than 500 cc's of aspirates. But if you're just getting 200, 300, in the past, the nursing will flag that and they'll stop it. But it's been found to be inaccurate because it could be related to gastric secretions, it could be related to medications, patient positioning, and other things. So really, unless they're clearly not tolerating enteral nutrition, this is the preferred route. All right, so when is parenteral nutrition used then? A, the nutrition is not tolerated. And that could be because of gut dysmotility, bowel obstruction, other things. And the other reason is supplemental of enteral nutrition. So in patients who are not tolerating like bigger volumes, if you do trickle or even trickle feeds or small volumes are still good to help maintain the gut mucosal integrity, and you can supplement that with TPN to achieve caloric goals. So the factors associated with infected pancreatic necrosis have been found to be age, and there's no specific number, but most studies really look at above 55. If you have more than 50% of the gland that is necrosed, that's more likely to get infected in the future. Delayed internal nutrition increases the likelihood of infection in pancreatic necrosis, as we said. Patients on mechanical ventilation, that's likely a marker of their overall poor status, and a high Apache score, which is the same thing, low physiological reserve. Infection in pancreatic necrosis raises the mortality to 30%. So it's a very important thing to watch out for. Oh, this computer is doing very funny things. Okay. Let me get back to where we're. Okay. All right. So
We don't see it yet. It's not being shared.
Oh, it's not. No.
No.
Let me see here. Okay. So do you see it now?
Yep. Yeah, we're
Yeah.
good.
So this is an important question that comes up is if somebody comes in with severe acute pancreatitis and pancreatic necrosis on CT, do you give prophylactic antibiotics to try to prevent infection since the mortality goes way higher and the sequelae are worse? And the short answer is no. It's been found to impart no improvement in mortality, no reduced incidence of progression to infected necrosis, interestingly. And what it does, though, is it increases the risk of multi-resistant infections if infection does occur. And it raises that from 21% to 78%. And it also increases the risk of fungal infections. And that's likely because it disrupts the gut microbiome, is the theory. And it raises that from about 5 to 8% to 20 to 30%. So, what can we do to predict infection then in sterile pancreatic necrosis? Um, there are a couple of inflammatory markers that may help. CRP above 150 within the initial 72 hours is strongly associated with development of infection later. But keep in mind that CRP is an acute phase protein. It requires 72 hours to peak. Um, these days we use procalcitonin, which is really more specific to bacterial infection, and it rises within 2 to 4 hours. It should be noted that there's a minimal response to viral infections. It does help distinguish, in general, overall, between bacterial sepsis from just systemic inflammatory response, and serial measurements may be valuable. However, I wouldn't, these are all, they don't help you individually to guide your entire idea of when the patient has developed pancreatic necrosis. These are just helping factors in terms of prediction. So this here, you could see, I don't know if you could see my pointer, but you see on the right side, there's perfused, brighter pancreatic gland tissue, and on the right side, it's lower attenuation, no contrast. That's necrosis. So really, it's the detection of infected pancreatic necrosis is predicated on a clinical assessment after reviewing the course of the patient. The first thing to keep in mind is that it typically develops after 7 days of the onset of pancreatitis. And what will happen typically is you'll have a patient that you've resuscitated, they're doing better. Um, and especially when you know they have necrosis, suddenly they get an increase of pain, they get worse, they may get even more unstable, renewal of their symptoms, they deteriorate clinically, fever, sepsis, bacteremia. Um, so it the suspicion of infected necrosis really is the other factor is persistent sepsis or progressive deterioration despite maximal support in the ICU. And early detection of this is critical because there are interventions we can do to treat this, and because untreated, the mortality, even with treatment, is high. So, to actually make a solid diagnosis, you need a positive culture of pancreatic or peripancreatic necrotic tissue by image guided fine needle aspiration biopsy, or from a drainage procedure if after 7 weeks they've developed a fluid collection that you want to drain, or an operation. That's one way. The other way is without tissue diagnosis. If you see gas and fluid collections, air bubbles inside the pancreatic necrosis on contrast enhanced CT, then that also is considered diagnostic of infected pancreatic necrosis. You can still do image guided FNA to kind of get microbiology and taper your antibiotics to it, but it's not strictly necessary for the diagnosis of infected pancreatic necrosis. So, as we said, clinical suspicion, then confirmation. So, just a very, very simplified algorithm. The patient's doing well, they get worse, they get fever. Clinically, they deteriorate after a week. And so you suspect that this could be infection. You repeat the CT. If you see air bubbles, you can treat. If there's no air bubbles, you can do a CT guided FNA of the pancreatic necrosis or any fluid collection that's there. Or if the patient is really doing much worse and you and it's the right timing and the right presentation, and it looks and feels like it's a super infection now of the pancreatic tissue, some people will just assume infection is present and treat. So that is, it's a bit of a gray zone. There's no strict guidelines here, but that is practice generally. This is not the same as prophylactic antibiotics, where the patient's doing well with resuscitation and you just add antibiotics for prevention, purely prevention purposes. So when you have suspected infection, you can go one out of two routes. As we said, you can get CT guided fine needle aspiration. And if it's negative, then you can assume that is sterile necrosis and they just need more supportive care. And you can repeat the imaging and fine needle aspiration every few days as clinically indicated. Or if you have a strong clinical suspicion of infection, and as we said, it's the right timing, the right circumstances, and they have necrosis, especially extensive necrosis, then you can empirically use antibiotics. Once you get any positive culture, though, then you can taper the antibiotics to that. If the patient with infected pancreatic necrosis is clinically stable, you can just continue the antibiotics and observe and try to delay any aggressive surgical procedures. And if they become asymptomatic with the antibiotics alone, you can avoid debridement or any other treatments, invasive interventions altogether. If they're still clinically unstable in the context of infected pancreatic necrosis, then that's when you escalate to further debridement. So initially, as we said, the patients will present with clinical worsening. So you have to do fluid resuscitation, pain control, then you start antibiotics. And your goal here is to stabilize the patient and control any systemic complications. You do serial imaging after that to monitor for the disease progression and identify any complications that can be treated, such as abscesses or fluid collections. And if the patient fails to respond to the antibiotics or develops complication, however, that's when you proceed to invasive interventions. So just before we go into the interventions, we'll talk about the antibiotic choice of what to use. The most common organisms are actually gut bacteria, which further supports the theory of the gut bacterial translocation seeding the infected pancreatic necrosis, which is why we said enteral nutrition is early to prevent this. So the spectrum of what you do should cover aerobic and anaerobic, gram-negative and gram-positive organisms. And then you de-escalate based on the culture and sensitivity results if you get fine needle aspiration tissue sample, or you get a sample from surgery. And in pancreatitis specifically, there's a notion called the antibiotic efficacy factor, which is the ratio between the bacterial spectrum covered by the antibiotic and the degree of pancreatic tissue penetration that that specific antibiotic can achieve, with a maximum efficacy factor of 1. So here are just some examples. So meropenem, imipenem are probably first choice in most intensive care units in North America with a very high efficacy factor. Ciprofloxacin is very good. The only problem with ciprofloxacin is the increased resistance patterns. So that has to be something that is well known locally, whether or not there's a local resistance patterns to this. And then there's other antibiotics. Oh, okay. I don't know why it keeps doing this. Let's see. Okay. Guess I should have emailed it to you.
You can still do it.
Yeah. Let me just do that quickly here.
Yeah, fine.
Yeah. Okay, I just emailed it.
All right. I'm looking at my emails. So. Is it a big file? Is it going to take a long time to come over?
It shouldn't be, no.
Okay. I don't have it yet.
Yeah.
Oh, yep, I do. 1 second.
Interestingly, I've been able to bring it back up, so.
I've got it up and running. You want me to run it? And then you tell me to
If
move
you see,
slides or?
yeah, if you're seeing it right now, we're probably good.
Okay, I'm seeing it.
Okay. So the indications for antifungal therapy, which we know fungal
Well,
infection.
we're still seeing your title slide, I should say.
Mm.
Okay. There you go. Good.
Yeah. So indications for antifungal therapy, since fungal infections are a common occurrence with pancreatic disease in general. Basically, to start this, you should first have proof of fungal infection, which is candida growth from the necrotic tissue culture. You can start empiric antifungal therapy if you're strongly suspecting of a superimposed fungal infection. And usually these are people that have had exposure recently to broad spectrum antibiotics, or they have a known colonization elsewhere with candida and severe illness. So if they meet all these criteria, then you can start empiric antifungal therapy. So empirical coverage of candida is not routinely recommended, and the antifungal agents of choice in severe pancreatitis are actually icannocandins, like caspofungin, micafungin. That's because the typical candida albicans that is sensitive to fluconazole and the azoles typically is not the organism that is responsible here. And these have been found to be superior in septic ICU patients with invasive candidiasis and candidemia than the azoles. So in terms of escalating to further intervention, the traditional approach used to be just basically a midline laparotomy with, surgical debridement. And there's been a landmark Dutch trial, the Panther trial, which have showed that the step-up approach is actually superior, because it basically, with surgery, you will get significantly higher rate of complications from surgical injuries, where you're injuring surrounding structures, and significantly increases the length of stay and morbidity. Mortality, interestingly, has not been found to be statistically significant, but that's likely a function of the numbers and the study designs. So the first step that we start with, which is the simplest, which is just image-guided percutaneous catheter drainage of any fluid collections, or if there are no fluid collections, of the necrosis itself. And that alone will be adequate in 35% of cases. And then you can repeat this many times, several times, if the patient is responding well and if they're not deteriorating clinically, as long as you're continuing the supportive care and the broad spectrum antibiotics. When this is clearly not enough and they're still deteriorating, or you require more, we've shifted more to video-assisted retroperitoneal debridement, which is also considered a minimally invasive procedure. But when compared head-on, actually draining it through endoscopic routes is actually even way less morbidity than video-assisted retroperitoneal debridement. So that will be the gastroenterology specialists that typically do this, and will be endoscopic kind of necrosectomy or cyst gastrostomy, usually with ultrasound guidance. And as a last resort, if the patient is still getting progressive deterioration despite all of this, then you can do laparoscopic or open debridement. So, as I said, there was no difference in mortality, but there's significantly less morbidity with the step-up approach, starting from minimally invasive all the way to the most invasive, depending on patient response. It lowers major complications and rates of multiple organ failure. It lowers long-term complications of pancreatic exocrine insufficiency, diabetes, incisional hernias, and other surgical complications. Better quality of life, lower cost overall. And it's just important to remember that the philosophy here is to provide source control for the infection rather than complete removal of all dead pancreatic tissue or potentially infected pancreatic tissue. You're not trying to do a complete procedure here. You're just trying to get source control to temporize the situation and bring the patient back. When we're talking about invasive interventions for pancreatic necrosis, it's best to delay until at least 4 weeks after the initial presentation. And this is especially more important for the last, more aggressive steps of resection, open resection or endoscopic resection, because you want to give it 4 weeks for the necrosis to wall off so that there's a clear demarcation plane surgically to remove only the necrotic parts of the pancreas and lower injury to surrounding organs, and remove less pancreatic tissue as possible so they don't develop long-term pancreatic exocrine insufficiency. Even if drains can be placed, however, prior to 4 weeks for fluid collection, suspicion of antibiotics or anything. But any attempt at actual necrosectomy should be delayed. The primary indication is for draining acute collections, walled off necrosis, is superimposed infection. So if these are just radiological phenomenon and the patient is actually doing well clinically, you don't really need to do this. Sometimes the fluid collections will be so big that they're pushing on the stomach and causing symptoms, and these are also indications for drainage. But if the patient is asymptomatic, doing well, thriving, and even if they're infected and they're responding to antibiotics alone and they're doing well otherwise, there's really no indication to escalate therapy any further. Other reasons, and these typically occur after the 3 to 4 week mark, is intractable pain, failure to thrive, feeding intolerance, and that's whether it's sterile pancreatic necrosis or infected pancreatic necrosis. And again, keeping that 3 to 4 week timeline is very, very important to minimize complications. So now we'll go over the biliary pancreatitis, since gallbladder disease is actually one of the most common causes of pancreatitis. And between that and alcohol, it's almost all cases. But biliary pancreatitis is responsible for up to 50% of cases, usually in women, the elderly, and you'll see clues like the ALT is more than 3 times the normal. And in this situation, endoscopic ultrasound is actually way more sensitive in detecting choledocholithiasis or impacted gallstones because of the overlying, because usually patients with pancreatitis might have an ileus. Clinically, we classically used to see the sentinel loops, dilated loops around it, which obscures the imaging on ultrasound. So endoscopic ultrasound is the most sensitive modality. These days, you can also do MRCP if you have that capability, provided that the patient is hemodynamically stable. Because again, MRI is a longer procedure, even a longer radiological test than CT, so you don't want to take an unstable patient there. In most cases, biliary pancreatitis being the etiology is usually a self-limited disease. You get one stone that passes then spontaneously, and you don't need intervention specifically for that. But then you'll have to think about removing the gallbladder later. In most cases, it's small gallstones and microlithiasis. These carry the highest risk, and they're very difficult to detect on imaging studies. So that is still problematic. Finding of sludge is also problematic because it's a lot of people will have sludge in their gallbladder, and you're not quite sure if it's just an innocent bystander or if it was the cause. Generally speaking, cholecystectomy is favored during the same hospitalization. And we'll talk about the timing of that a bit later. Okay, so in some situations, you will need to perform an emergent ERCP in the context of biliary pancreatitis. And the criteria for that is if they have clear signs of ascending cholangitis from a stone or some obstruction in the distal bile duct that is causing both the pancreatitis by obstructing the pancreatic duct as well as the bile duct, which you think is infected. So that's a solid indication for ERCP and biliary pancreatitis. Or if they have ongoing biliary obstruction from a stone impacted at the ampulla, and this can be verified with either endoscopic ultrasound or MRCP, as long as the patient is hemodynamically stable. But it's not, ERCP is not routinely indicated in all cases of biliary pancreatitis because ERCP alone may exacerbate or worsen the pancreatitis, especially with pancreatic ductal cannulation. These days, they leave stents in the pancreatic duct, which lower that risk, but you're still introducing a risk. So if in a situation where you have a patient with acute pancreatitis and you have ascending cholangitis or a persistent stone that is obviously patient is not going to get better without resolving that obstruction, but you don't have ERCP capabilities or percutaneous TC available to drain the bile ducts, then that is an indication for open common or laparoscopic common bile duct exploration in that situation because it's the only way to relieve the obstruction. And what you do is you go into the bile duct, you clear the stones. Classically, they would close this over a T-tube, but that today is not done. Most of them are closed primarily just by suturing the common bile duct opening through which you went through. Because they found that closing it directly like this is basically leads to fewer bile leaks, shorter length of stay, shorter time. But T-tube is used. When it will be used is when you have marked inflammation of the common bile duct, concern for residual stones, suspected distal stricture obstruction, or very small friable common bile duct where you think just suturing it directly will fail. So that's a clinical intraoperative judgment. So, management of the gallbladder in the setting of biliary pancreatitis, it's usually, if it's mild edematous pancreatitis, we used to wait 6 weeks after resolution of the pancreatitis in those cases traditionally, but it's been found that cholecystectomy during the same admission is safer, more feasible, and leads to better outcomes. If the patient happens to not be a candidate for the surgery itself because of systemic underlying severe COPD, severe cardiac or valvular disease of whatever reasons, because of medical comorbidities, then you can do an ERCP with sphincterotomy. Again, this is all after the patient has resolved from the acute pancreatitis episode. In severe acute pancreatitis, we still like to wait 4 to 8 weeks after resolution before going in and removing the cholecystectomy. Because remember, these are patients with significant local inflammation and have had a very rocky course. All right, alcohol, as we said, it's about 30% of cases. On history, it is sometimes difficult to tell if the patient is not upfront exactly about how much alcohol and episodes of binging, but this rarely is the cause when there's no underlying chronic pancreatitis. Because one single binge doesn't typically lead to acute pancreatitis. So these will be patients with a history of alcoholism and underlying chronic pancreatitis and multiple problems, and then they come in with another pancreatitis episode, and this one happens to progress to being severe. And alcohol, part of the other reason it's difficult is no known safety threshold. It's difficult to quantify what type of alcoholism will actually lead to pancreatitis. So we go by if they've had a history of chronic pancreatitis. Drug-induced is a more rare cause, and it's really more difficult to tease out whether this is the cause or not. But there's been more than 300 drugs that have been reported in various case reports and studies as potentially causative. The reactions are idiosyncratic, meaning they're rare, unpredictable, not dose-related, and the mechanism is thought to be immune-mediated, actually. It is common for patients to be on one of the drugs that I will show you, but it's difficult to determine whether the drug is the actual cause, whether it's the culprit, or if it's just an innocent bystander. So there's drugs with definite association, and the ones with asterisk next to it are particularly been related, particularly been known to cause acute pancreatitis. But again, the list is massive, even antibiotics, steroids, other things. All right, and so another complication, which is often forgotten, it makes for good testing for exams for surgical residents, is abdominal compartment syndrome as a cause for patient deterioration after the pancreatitis has resolved. And this is more likely when the patient has received massive amounts of fluid for resuscitation. And you suspect it again with onset of worsening of respiratory distress, decreased urinary output, tense abdomen, and as I said, a history of a recent large positive fluid balance. So you can diagnose it just from the clinical picture alone. Classically, bladder pressure measurements are used. If the bladder pressure is more than 18 millimeter mercury, then that's intra-abdominal hypertension. But it's above 20. If it's 21 or above, that is diagnostic of abdominal compartment syndrome. But as I said, bladder measurements are not strictly necessary. If you see someone with pancreatitis who's clinically worsened and you go and assess them at the ICU, and they got a very tense abdomen, urine output suddenly went down, now the respiratory distress is worse, and you look at the history and they've received 13 or 15 liters of fluid recently, then there's a very strong suspicion for that, and that requires immediate decompression. All right, so causes of recurrent unexplained acute pancreatitis. There can be genetic factors, obesity, diabetes, smoking, environmental toxins. So it can be very difficult to figure out when it's idiopathic. But what you should do is rule out some congenital pancreatic issues that predispose to pancreatitis, such as pancreatic divism. And usually these are people who have had problems since early life. You got to rule out ductal strictures, ampullary lesions such as periampullary tumors, gallstones that are obstructing that are not visualized on ultrasound. And in some cases, you can do an ERCP with sphincter of Oddi manometry to detect the increased pressure of the sphincter of Oddi, which can be easily treated with a sphincterotomy at the time of ERCP. So if the patient is having recurrent unexplained acute pancreatitis, the workup includes an endoscopic ultrasound and or MRCP. with sphincter body manometry. And generally speaking, even with patients who have no gallstones on ultrasound, a cholecystectomy is recommended after a second episode of idiopathic pancreatitis, because as we said, it could be microlithiasis that is causing it, microcrystals, stones, and we do this to reduce the risk of recurrent episodes. But
thanks for a
all right, so I'll just end up here. So in summary, patients with pancreatitis who present with organ failure or signs of a systemic inflammatory response should be admitted in a monitored bed setting, usually intensive care. The fluid volumes need to be reassessed at frequent intervals. It's usually the first thing you have to pay attention to when the patient deteriorates, worsens, or fails to improve, to make sure that we have the goal-guided resuscitation of fluids. Do not start antibiotics for sterile necrosis. There has to be a very strong suspicion or proof of infected necrosis to start antibiotics. Early enteral nutrition is key, and this should be thought about within the first day if they can tolerate it, to start some oral nutrition, as long as they're not hemodynamically unstable on pressors, where you get decreased splanchnic circulation. If the patient fails to improve within 72 hours, or you suspect development of infected pancreatic necrosis, usually that happens later, then repeat imaging. And empiric antibiotics, as we just mentioned, really should be done when you have some imaging combined with clinical, combined with potential tissue diagnosis. Thank you.
Great. Thank you very much, Ali. It's a great detailed analysis. Not terribly uncommon general surgical emergency. Can I? I'll ask a couple of questions and then we'll take questions from other people. When I was a student, when I was training, we talked about acute pancreatitis as the internal burn, right? In terms of all of that third spacing, etc. Should we still consider it the internal burn? And if we look at, let's say, any literature on cytokine profiles between, let's say, or comparing severe burns with severe pancreatitis, do the two pathologies have the same cytokine profiles?
So the that's a very good question. It's a much worse cytokine profile. It more correlates, the thinking is, with the systemic inflammatory response. So it's not necessarily specific to the acute pancreatitis process itself. And that's why a lot of research and people have tried to hone in on inflammatory markers like CRP, procalcitonin, and a lot of studies have come up with certain cutoffs for that, but it's not specific to acute pancreatitis. It's rather a symptom of it or a consequence of it.
Right. Okay. And then talking about inflammatory or pro-inflammatory markers, etc. Should we be looking at lactate clearance? In other words, if the patient comes in, acute pancreatitis, severe SIRS, and you draw a lactate comes back high, right? Is it useful to direct therapy looking at the lactic acid and hopefully seeing it clear? And then also, is LDH still something that is useful in terms of identifying the patient at risk for developing severe necrotizing pancreatitis?
Yeah, so the lactic acid is an important marker in critically ill patients in general. In terms of what guides our actual management, it's more the clinical markers such as the heart rate, the blood pressure, the mean arterial pressure, urine output, things like that, and not necessarily strictly the number itself of the lactate. So that's not a guide in itself. However, if you have high lactate or elevated lactate that elevates much further later on or fails to clear, that could be a marker that something else is going on. So you have to rule out other necrosis, other issues that are going on. It's a marker. It's a very useful marker in hypoperfusion and shock and systemic injury, but again, not very specific to acute pancreatitis itself. It's rather like a consequence, or what else is happening, or is the resuscitation failing? In terms of the LDH, it is useful, but again, it's in the same category. It's actually part of the Ranson's criteria that were classically measured. But in terms of large studies, meta-analyses that looked at specific factors, that number alone hasn't been necessarily correlated with severity or resolution of acute pancreatitis. Interestingly, hematocrit, blood urea nitrogen, things like that have been more accurate and more specific to pancreatitis.
Right. And again, related to the delayed ransom or the 48-hour ransom criteria, right?
Correct. Yes.
Right. Okay. One other question. Yeah. I'm sorry.
Sorry. No, I was going to say yes. It's part of the assessing it initially and then at 48 hours.
Right.
It's one of the Ranson's criteria.
Right. Okay. One last question I had. You talked about antibiotic choice, right? And the efficacy factor, and then looking at pancreatic penetration. How do you calculate the pancreatic penetration of antibiotics?
So antibiotics have different antibiotics have different penetration in different tissues,
Right.
like for CNS tissues, things like that. And it's found specifically for pancreatic tissue, some antibiotics have a predilection for penetrating deeper into pancreatic tissue and being more effective, whereas other antibiotics, which might cover the full spectrum, you don't achieve adequate concentrations in the pancreatic tissue when they've measured it and looked at it retrospectively. And that's how the carbapenems and ciprofloxacin really come on top, because they have high penetration into pancreatic tissue.
Right. So these are sort of generally accepted guidelines for the various antibiotics, right?
Correct. Yeah. Practically, now people will start with imipenem or meropenem right off the bat, and then they will narrow it down if they get any samples from FNA biopsies, or if the patient happens to go for surgery and you send some of that pancreatic tissue off and for culture and stain.
Got it. Okay. Anybody else with any other questions before we wrap up, since it's the top of the hour? This is really interesting. I mean, it gave us a nice overview, and it was also good to sort of hear what's up to date. In particular things like resuscitating, not flooding these patients with fluid, and then the next thing you know, you end up intubating them with pulmonary edema. Right.
Yeah, because then they start to develop complications just from that. So these are iatrogenic complications.
Yeah. Sometimes less is more, and more is less.
Correct.
Great. Well, thanks very much, Ali. Thank you. Thank you, everybody, for attending. We've got another talk in 2 weeks' time, actually from one of our own local experts, Dr. Ori Wiesel, talking about the management of lung cancer in underserved areas of Israel. So that will be on the 30th of June, same time. But again, Ali, thank you. This was great. And it's recorded, so it'll end up on the YouTube channel, so everybody can watch it next time. Again, thank you very much. Everybody else, have the rest of a great day. Thanks a lot. Ali, thank you.
Thanks.
Bye, everybody.
Thank you.
Bye.